Good. Okay, we have a quorum and we're about to begin. The chair is, what, today is February 22nd, 19. Well, I already. Going back in time, 1950, and I arrived that day. How about that? Anyway, it is February 22nd, 2023. Our chairman is out in another committee having a bill hearing. So I'm Senator Kathy Klotzmeyer, the vice chair, and I am taking over. And then for a little while, and then I have two bills, and Senator Hayes will be taking care of business for a little bit. But in the meantime, we will have Senator Ellis. And he will be giving Senate Bill, wait a minute, 511. And I just also have to say, the chair is out having a bill hearing, and you may see that there's not some of the senators are not in their seats, but it's good to know that they all have bill hearings in other committees as well. So that's how we'll roll. So Senator Ellis, take it away.
Okay. Thank you, Madam Vice Chair and members of the Senate Finance Committee. I'm Arthur Ellis from District 28, Charles County, serving in the Senate of Maryland. I'm here to present to you today Senate Bill 511, Health and Human Services Transportation Improvement Act of 2023. This bill covers non-emergency medical transportation for the rural counties. So huge problems in the rural counties. You don't have access to rail, regular bus service. And so individuals who are lower income, disabled, and especially seniors have a lot of issues in getting to their medical appointments. So this bill aims to put a solution to that problem by requiring the governor each year to put $1 million in the rural non-emergency medical transportation program to help alleviate this problem. Now let's talk about the size of the problem. 1 out of 5 missed medical appointments are due to transportation problems. That's around 76,000 to 82,000 Marylanders based on national statistics. You look at this population who miss their medical appointments, they're usually at the poverty line or below. In one study, over half of transportation disadvantaged were below the poverty line. A review of published data in the Journal of Health found that 25% of low-income patients missed or rescheduled their appointments due to a lack of transportation. Also, you're looking at over the entire 18-year study period for the previous mentioned study, employment rates range between 23 and 24% at the initiation of dialysis for individuals, and a decrease from 37 to 38 from 6 months before the end-stage renal disease onset. As an offset, 81 to 85% of adults in the general population with similar age are employed, including more minorities and women representation. There was a Baltimore study which found that Black patients were 1.8 times more likely to miss appointments, and Latinx patients were 2 times more likely to miss appointments compared to white patients. Lack of insurance, out-of-pocket costs, cultural and logistic barriers are impediments to access appointments, which leads to transportation problems. So a lot of data we have on what the problem is in Maryland, and this bill, Senate Bill 511, will, if passed, will take a big step forward in helping to solve this problem. So on the panel today, 2 individuals represent in the Tri-County Council for Southern Maryland, and the Rural Maryland Council. They will introduce themselves, and I won't give their testimony, but I just say these individuals are well knowledgeable about the rural issues across Maryland. So we have a long day. I'll end my testimony. I'll save time and not include all the data that we have here. And I'll include that in the bill file. So, Madam Chair, committee members ask for a favorable report on Senate Bill 511.
Thank you very much, Senator Ellis. And I just would like to say welcome to Senator Hedelman. That we have, this is a dual bill that's being heard, and she is from Budget and Tax. She's our secondary person. So welcome. Okay. State your name, say your name, and keep on going.
Thank you, Madam Vice Chair, members of the committee. My name is Charlotte Davis. I'm the Executive Director of the Rural Maryland Council. We're an independent state agency located in the Maryland Department of Agriculture. We administer 2 grant programs, the Maryland Agricultural Education and Rural Development Assistance Fund, as well as the Rural Maryland Prosperity Investment Fund that includes a component related to healthcare and improving access to healthcare in our rural areas. Over the last several years, we have been funding several different approaches to transportation and healthcare, from the volunteer model to utilizing idle buses for adult daycare services or developmentally disabled services, to mobility management through the community action agencies. We've tried everything and they all are struggling. So we decided to take a closer look at this issue and partnered with the Tri-County Council of Southern Maryland and hosted a series of roundtables this past fall. We held them across the state. We felt we had really good participation. We had overall 155 participants to discuss and come up with solutions to this challenge. We coalesced and came to consensus that one, we need better coordination amongst the different agencies. The health industry sectors and the transportation sectors often do not communicate. And so definitely saw a need for better coordination. The state had a coordinating committee that was established under executive order under Governor Glendening. However, it hasn't met since 2016. So we would like to see that reestablished and codified and then reinvigorated with its membership and its charge so that we could have that coordinating entity to have these sectors just, you know, we see silos across the board and we want to have better communication from them. We also heard from everybody that we definitely needed additional resources. So, and then finally, we just wanted to say we need a new transit model for rural. It needs to be less fixed route, more on demand, smaller vehicles, and definitely a much more regional approach to transit. So with that, I ask for your favorable support of Senate Bill 511, and I thank the sponsor for putting this bill in for us.
Thank you. Okay, next.
Thank you for having me here, Senators. My name is John Hartline. I'm Executive Director of the Tri-County Council for Southern Maryland and former Chairman of the Rural Maryland Council. We started working on non-emergency health transportation back in 2017. We did it with a study that was funded by the Rural Maryland Council. We began the program in 2018. We have been operating it for we're in our 5th year now. We've learned a lot from that. We had set as an original objective to carry people to doctor's appointments who had no other means of getting to and from doctor's appointments or hospital visits. And we were surprised at the amount of demand that was being unmet. We worked with Calvert Health Hospital and St. Mary's Hospital. After some success, and by success, I mean we've shown that sometimes the return on the investment could be 5, 6, 7 times the amount that was spent on the transportation. And we've continued the program in the hopes that we could do this in a more statewide manner. As Charlotte has told you, we did a roundtable and we found that we weren't alone, that the problem exists in all areas of the state. Each area is using a slightly different model, but the one that we have results in significant improvement by the patients and their recoveries. It helps people who have no other means of transportation to and from the hospital and to their follow-up visits. And it does result in substantial savings to the hospitals. And that's why I'm here to support this bill and ask from you for a favorable report. Thank you.
Right on time. Is Tricia Swanson here? Oh. I can see you sitting over here.
Good afternoon, Madam Vice Chair, members of the committee. My name is Tricia Swanson, and I am the Acting Director of Government Affairs for Care First Blue Cross Blue Shield, here in support of Senate Bill 511. Care First has taken a particular interest this session in transportation and transit bills, both as a large employer in the state and also as a carrier focused on social determinants of health. A few weeks ago, Care First testified in support of a bill that focused on transit-oriented development sites. So as such, we wanted to come to the table to support enhanced transportation programs and coordination for the more rural jurisdictions in the state. We have members in every jurisdiction in Maryland, and with that perspective, we have visibility into how regional barriers to transportation lead to missed or delays doctor's appointments or clinical appointments, fewer prescription refills, and overall poorer health outcomes. All of these contribute to an increased economic burden on the healthcare system and overall community health, directly affecting people's access to much needed healthcare services. So while we're not in the transportation business, as a healthcare company, we're proud to join in support of this bill to call for investments to connect people to the care that they need. This bill takes the right step forward in making those investments and also setting up the State Coordinating Committee for Health and Human Services Transportation to analyze Maryland's transportation needs and coordinate efforts across the state. Thank you for the opportunity to testify, and we respectfully urge a favorable report.
Thank you. Do we have Mandy Arnold? Mandy Arnold? Okay. So we have one more person named Erin Farley, and she's virtual. And then we'll open up for questions.
Good afternoon. My name is Erin Farley. I am a nurse, a mother of 6 children, and I have 2 parents over the age of 80 who have been lucky to utilize one of the programs in Calvert County where we live. My parents and I don't have any other family other than those children in our community. Rural Calvert County is 50 miles from one end to the other. We do have a public transportation system. However, if you get on that bus, you have to ride that whole loop to get back off that bus again. So, you know, my parents are very proud. My father is sharp as a tack and does not move well. And my mother has dementia, but she moves well. They are interlinked as a team. We found ourselves in a situation where we had an acute illness. My father was a government worker. He has Federal Blue Cross and Blue Shield, but they, you know, they are on a budget. They're retired individuals. And we found ourselves in a situation where we needed to get to 4 and 5 doctor visits a week. Well, he was not allowed to drive. He was unable to drive because he was unwell, and she can't drive. So you end up in a situation where you have, and I'm as a nurse, ER over 20 years, and you end up in a situation where you have 2 individuals who are proud and aren't going to reach out for help. So they make decisions, and they're not the best decisions. They make decisions and not speak to their doctors. And the first decision they make is, well, out of all these appointments I need to get to, if I can't get to them and I only have a ride certain number of days a week, then I'm going to prioritize what I think is most important. Well, as a nurse and as his daughter, I don't think that we were prioritizing the same way. Being septic and just out of the hospital, we needed to make sure he got the care that he needed. And our program here in Calvert County works for that, but that's a limited program.
Okay, thank you very much. Are there any questions for the panel or or for Ms. Farley? Seeing no questions, that ends the hearing for Senate Bill 511. Thank you very much for everybody's testimony.
Thank you.
They're not too rowdy. I need to, I have a bill hearing, so Senator Hayes is going to take care of business.
474.
Good afternoon, committee members and finance. Senate Bill 474 is a managed care organization's acknowledgement of responsibility for payment of retroactive denial. It's a repeal. Good afternoon, Chair Griffith and fellow Finance Committee members. I am here today to present Senate Bill 474, Managed Care Organizations Acknowledgement of the Responsibility for Payment of a Retroactive Denial and a Repeal of that. I'm not going to say that word. I can't say that. But it's the repeal of that. The purpose of Senate Bill 474 is to ensure that if a carrier is the primary payer of a claim, an MCO is not responsible for guaranteeing payment of the claim by the responsible carrier. As the payer of last resort, MCOs, Medicaid should not be held responsible for the payment of a claim that should be paid by a private payer. Every MCO is obligated to communicate at the time of the retroactive denial that another payer has been identified as providing coverage to the member. Submission of the claim must be made to that payer since Medicaid is the payer of last resort. Otherwise, the Medicaid program will be paying claims with state dollars that should have been paid by a commercial payer. If there is no change in the current law, the result will be additional state dollars spent on claims that should have been covered by private carriers, resulting in a violation of the state and federal rules that intend for Medicaid to be a payer of last resort. In addition, the state will inappropriately experience an increase in the amount of state Medicaid dollars spent on claims. It is for these reasons I request a favorable report, and I would like for this sponsor panel to come up. Kathleen Logren, Jennifer Bierman, Jason Rotman, and Annie Coble.
Good afternoon, Mr. Chair, members of the committee. I'm Jennifer Bremen, Executive Director of the Maryland MCO Association. I'd like to thank our sponsor, the Vice Chair, for bringing this important bill before you this session for consideration. The Maryland Managed Care Organization Association represents the 9-member Medicaid MCOs that serve over 1.5 million Marylanders through the Medicaid Health Choice Program. That's roughly 1 in 4 Marylanders that have healthcare coverage through an MCO. All 9 MCOs that serve Maryland's Medicaid program strongly support the passage of this legislation. The managed care organizations that serve Maryland's Medicaid program are committed to identifying ways to improve access to quality health care for all Medicaid participants, as well as identifying efficiencies to improve the Health Choice program and its cost-saving potential to the state of Maryland. We believe that this bill does both. It has a great cost savings potential for the state and the bill's provisions, if enacted, will make the Health Choice Program a more efficient one. For these reasons, we respectfully urge a favorable report on Senate Bill 474. My colleague Kathleen Loughran, who also holds the leadership position within the Association of Government Relations Chair, will go into the details of the bill. Again, we thank you for your consideration of Senate Bill 474, and we urge a favorable report on the bill. Thank you.
Thank you, Madam Vice Chair and sponsor of the bill, as well as Jennifer for the introduction. In addition to being the legislative chair of the MCO Association, I am with WellPoint, Maryland. We are the second largest MCO in the state, and we have been in the program since its inception. You may know us formally as AmeriGroup. This legislation before you today is important because recently there was an interpretation of law that stated an MCO may not retroactively deny payment to a provider even if another carrier is responsible for that payment, unless we obtained a written acknowledgement of responsibility from that carrier. We are not in a position to be able to obtain that written statement. We have had conversations with the Maryland Department of Health. They are supportive of our efforts to repeal that provision. They have also had conversations with CMS. We believe you will be getting a letter of support from CMS. CMS supports the legislation as well because it is viewed as a barrier to having an MCO, ultimately the Medicaid program, be the payer of last resort. And you would then be requiring the state to pay claims that are not owed by the state, but are in fact owed by a private payer. And I will tell you that the rates that are set by the state for the MCOs account for our ability to conduct coordination of benefits, and that the state builds in efficiencies in the MCO rates based on the fact that there is a certain dollar amount that will be recovered because those monies should never have been paid by Medicaid. The state, MDH, provides the MCOs with information as to who the primary payer may be for a member, and they give us that information that we then in turn use a vendor to verify and communicate to a provider that that is the responsible entity for payment, not Medicaid. There are protections in the law, in the retroactive denial and in the prompt pay law to ensure that providers are allowed to then pursue those payments as if the claim submission is being submitted for the first time. So they're still protected under their ability to submit within 6 months, and they still have the ability to prompt pay and all the benefits that come from there. The only other thing I'll add quickly is that we know that the providers have concerns about the language. They're concerned that with the removal of this provision, they would not be entitled to know who the responsible entity is. I would submit to you that if you look at the current language, that we are not disturbing, the fact that we have to provide specific information as to why we are retroactively denying would include the information about who that payer is. Now, let me wrap it up and move on to my colleagues, and they can talk a little bit about that. And then, of course, we're happy to answer any questions you may have. And with that, I'm going to turn it over to Annie Coble with Priority Partners.
Good afternoon, Senators. Thank you, Madam Vice Chair. My name is Annie Coble, and I'm representing Priority Partners and expressing our support for SB 747 as a member of the Managed Care Organization Association. Priority Partners is jointly owned by Johns Hopkins Healthcare and Maryland Community Health System and is the largest MCO in the state with over 360,000 members. We support SB 474 and its intent to ensure that Medicaid is the payer of last resort as is required by federal law. Without this bill, there is a real risk of the state inappropriately paying claims through Medicaid that the commercial carrier should be paying. Therefore, to protect Medicaid funds and to ensure it remains the payer of last resort, we urge a favorable report on SB 474.
All right, thank you, Madam Vice Chair, other distinguished members of the Finance Committee. My name is Jason Rotman. I'm the CEO of Maryland Physicians Care. Maryland Physicians Care is a Medicaid managed care organization, and we are owned by 4 hospital health systems: Holy Cross in Montgomery County, St. Agnes in Baltimore City, Meritus in Washington County, and UPMC Western Maryland in Allegheny County. We manage over 250,000 Medicaid recipients and operate in all counties in Maryland, including Baltimore City. Medicaid, as has been stated, is funded jointly by federal and state dollars and is required by federal regulation to be the payer of last resort. This means that we have a fiduciary responsibility to collect money when we are aware of another payer. MCOs have multiple ways we get the data of who might have other payers that are responsible for coverage. This includes from the state, from the members, sometimes from providers, and very often from a national clearinghouse that almost all payers participate with, where we share and gather this information. And while we make every effort to get this information timely, that data is constantly changing and is often not available at the time that the claim is paid. For many years, the practice of MCOs has been to recover overpayments from providers when other coverage is identified after the claim is paid. The ruling over the summer, which has been referenced, which clarified existing law and said that we need to get acknowledgement prior to recovering the claim, is problematic because there is no mechanism for an MCO to gather acknowledgement of the other payer. Medicaid claims are paid via electronic processes, and for those electronic processes, there are clear legal frameworks, turnaround times, and other enforcement mechanisms, all of which don't exist for payer to payer to get an acknowledgement of responsibility. So if Senate Bill 474 is not enacted, then the MCO's ability to recover the medical expense from the rightfully born payer will be dramatically impacted. This will also result, as has been stated before, that the Maryland Department of Health will have to increase Medicaid capitation rates to cover this expense, because there is a requirement from CMS that those rates be actuarially sound. Thank you. Appreciate the hearing today.
Thank you, Madam Vice Chair, and for your panel. Are there any questions for the sponsor in this panel? Senator Lamb.
All right, thank you. And thank you to the panel. I was looking through the bill folder, and it seems like the main objection coming from those who are opposed to this is the foregoing the requirement of identifying the name and the address and the entity involved in denying the claim. And I think this was what Ms. Loughran, you were talking about earlier.
Mm-hmm.
And it sounds as though, maybe there's a middle ground where, because it sounds like, based on what you were saying, that information oftentimes is already provided. So, I'm trying to understand why there's a disconnect between you saying that a lot of this information is already provided, and then the contention here that, it's not included in the bill. And so would you be open to an amendment just saying that would be the name and the address has to be a required field that has to be offered as part of that?
So thank you, Senator Lamb. I appreciate the question. Committee members, we value the provider participation in the Medicaid program. It's critically important, as you and others know. The more providers, particularly in certain areas, certainly the better. So we think that payment of those providers is really a cornerstone of their participation, right? So we do believe very strongly that they need that information. I think that the notice that we have to provide, that's in a separate section in there, would require us. And I think if the commissioner saw that we provided a retroactive denial with that details about where they need to go for that payment, she would find us in violation. But I also understand from my conversations with Ms. Kaufman that there are some concerns that that's not specifically stated. So I think we're going to try and work over the next few days to find a middle ground. Our intention was not to be disruptive to the insurance law, but to protect the MCO Medicaid program. And so that's where we went to make changes. So if we can do that and still maintain the integrity of the current law and not bring more people into the fray, then we're certainly happy to try to do that.
Okay, so
Thank
it
you.
sounds like maybe there's some possibility to work this out and it may be close, I guess, because it just sounds like you provide that information anyway. That's the information that the opponents are asking for. If there's some way to kind of figure that out, that would be great.
Right.
Okay, thank you.
Thank you.
Are there any additional questions for the sponsor of this panel? Thank you. I think there's one more person signed up to testify unfavorable. So if you guys will switch places with Dana Kaufman.
Good afternoon. Thank you very much. My name is Dana Kaufman. I'm here on behalf of MedChi, the Maryland chapter of the American Academy of Pediatrics and the Mid-Atlantic Association of Community Health Centers. And we do have concerns with this bill. We think we can work it out though. And just to let you know, the retroactive denials when there's a coordination of benefits. So our concern is the physicians and healthcare providers have already rendered this service. They've already provided the healthcare. And up to 18 months later, they can get a notice saying that their payment is due back. So we just want to make sure and make it very clear in the bill that we have an avenue to get the payment for the services already rendered. It's already hard to manage, especially smaller offices, when you can have payments requested up to 18 months. So when you take out this provision, what's left is language that just says that provide the healthcare provider with a written statement specifying the basis for the retroactive denial. We might be a little bit paranoid, but we would like it to say, including the name of the carrier and address, so we can then be able to submit the claims. And I think that that would do it. And we need to make sure again that we don't affect the other insurance articles, but you know, we can work with them and work with committee counsel for that clarity.
Are there any questions for Dana? Seeing none, thank you for your testimony. Next bill, Senate Bill 530, sponsor Senator Vice Chair Klausmeier. And I believe once she gets to the table, she's going to call up the members of her sponsor panel.
Good afternoon, committee. Senate Bill 530, Insurance, Maryland Automobile Insurance Fund Assessments. Due to a variety of circumstances, the Maryland Automobile Insurance Fund MAIF surplus has significantly declined over the past several years, and a private passenger assessment is imminent. This has occurred largely due to a 20-year gradual shift in policies from MAIF to the private market. In 2004, MAIF had 122,000 policies and collected $241.5 million in premiums. Today, that has decreased to 24,000 policies and $53.3 million in premiums. If we continue on this path with no changes to statute, an assessment will be inevitable. Senate Bill 530 addresses this situation in two ways. First, it amends Insurance Article 20-401 to allow MAIF to directly assess nearly $10 million in overpayment credits without insurers and their policies holders being charged for the assessment. Second, Senate Bill 530 amends Transportation Article 17-106 to alter the formula which provides funding to MAIF from the uninsured motorist penalty fines collected by MDOT and MVA. By amending the Transportation Article, The bill will provide MAFE additional funding to assist the uninsured division with operations and the insured division with rate inadequacy to avoid or reduce an assessment on the insurance companies and their policyholders. I'm here with MAFE Executive Director Al Redmer, who can go into more detail on the current situation and why this legislation is needed. The committee should also know that there was a minor drafting error in the amendment, and I have drafted to address this in your packet. I want to thank the committee for their attention, and I am requesting a favorable report on Senate Bill 530. Good
Madam Chair.
afternoon, Madam Chair.
Madam Chair, members of the committee, thank you for allowing us to be here with me. This afternoon is Dave Pfeiffer, our COO, Sandy Dotson, our Government Relations Manager, and many of you recognize Dennis Carroll, who's had a long distinguished career as a regulator and in the private sector that works both in our legislative affairs as well as for our general counsel. And thanks to Senator Clausmeyer for her willingness to sponsor this legislation. For primarily as a refresher about Maryland Auto and what we do. We were created by the General Assembly 50 years ago. We perform a couple of functions. Number one, for any of your constituents that are injured by an uninsured driver and they don't have insurance themselves to pay claims, MAFE, Maryland Auto, we step in on behalf of the state. We pay those claims on behalf of your constituent, and then we seek reimbursement from the uninsured driver that inflicted the claim. Additionally, we were created to be the state's insurer of last resort. If your constituents can't get coverage from any other insurance carrier, we will provide them coverage regardless of their circumstances. And by providing this coverage, our goal is to reduce the number of uninsured drivers in Maryland. According to industry statistics, 1 out of every 8 Maryland drivers currently is driving without insurance. And I invite you to remember that as you drive down 97 or Route 50 or wherever you're going home, any of Maryland's beltways. And it's important to note that we cannot accept all drivers. We can only accept those drivers that have been canceled by their current carrier or turned down by 2 others. So naturally, we accept the poor drivers with high claims, and we can't offset those losses with good, profitable drivers. So naturally, our claim expenses as well as our operating expenses are generally much higher than the traditional carriers providing auto insurance. And it's also important to note that our mission and our statute requires us to look at affordability of premiums. As you can imagine, when it comes to people driving without insurance, affordability is the number one reason that prevents your constituents from buying the coverage that they need. And regarding affordability, we do that by a self-imposed affordability cap. We look at the zip codes in Maryland, the median income, and we strive to keep our premiums within 2.5% of the median income in that zip code. So if you are in an affluent zip code and you have to come to Maryland Auto, you're pretty much paying the full load based on the claims and expenses to do business in that area. But if you are in a low income community, we are subsidizing losses to a significant extent. Just like traditional carriers, Maryland law requires us to hold an adequate surplus of funds. This is a sum of money held in reserve to pay future policyholder claims. If our surplus drops to a certain level, it triggers an industry assessment. And that's a process where the state sends out a bill to all of the other carriers based on their market share. And that money comes to us directly to our surplus. And it's important to note our last assessment was about 30 years ago. Now the carriers will recover that assessment in one of 2 ways. Typically, they will either charge a surcharge on your constituent's policy, or they'll increase the rates to cover that expense during their rate making process. Now, for the last 20 years, our business measured by policies and premium have steadily declined. During that period, private insurance companies have increasingly been able and willing to write a larger part of the market. And that's a good thing. And the decline is reflected in a substantially lower MAIF surplus. But it's important to note that recently that pendulum has changed and conditions have reversed, where the industry has become more restrictive. They've tightened their underwriting standards, and more policies have come to Maryland Auto, which means we lose money faster. So as Senator Klossmeyer mentioned, the bill does a couple of things. It provides funding to MAIF through the ability to access $9.5 million in over recoupment payments that were received 30 years ago in the event that we trigger an assessment. And then secondly, it alters the formula to the funding of the uninsured division. So I mentioned that we pay claims for your constituents that are injured by an uninsured driver and don't have collectible insurance. I'm getting the high sign. That's currently $4.5 million. We've changed that formula to be 20% of the total, which would allow us to pay our uninsured claims and fund some of the unsustainable losses in those areas where we have the affordability cap. And with that, Madam Chair, happy to answer any questions that you might have.
Good afternoon, Chairman Griffith, Sandy Dodson with Maryland Auto Insurance Fund. I'm just here for questions.
I'm Dennis Carroll. I'm also with Maryland Auto Insurance Fund. I'm really here for questions. The one thing I would just add to what Al said was that if the bill passes, it becomes much less likely that we will have an assessment. The assessment ultimately becomes a bill on individual insured people. So it's all insured drivers in Maryland will get a bill if we have an assessment. If the bill passes, it's much less likely we'll have an assessment. And we'll either delay or reduce the size of the assessment and may avoid one altogether for the next few years. Without the bill, an assessment is imminent. Thank you.
And good afternoon, I'm Dave Pfeiffer. I'm the Chief Operating Officer, and as Sandy, I am here primarily for the questions.
Hey, thank you very much.
As usual, Madam Chair, I took all the time.
Are there questions? Senator Vital.
Thank you, Madam Chair. So for Mr. Redmer, I'm really amazed at the numbers from 2004, really to 2014, where the big drop was, and now almost half of that again. Is that because other substandard carriers are taking kind of the cream of the crop of the substandard carriers?
Yeah, it's due to that as well as technology. You know, when I was a young guy in the insurance business, and that was a long time ago, you know, and if you came to Al and you wanted to get an auto quote, I would ask you like 6 questions. I'd find out what kind of car you drive, and I'd take that big book off the shelf, and I would go into the rate book and figure out what your premium is. With technology and with data that's available, all these carriers have these sophisticated, complex algorithms where they take that information, but they pull publicly, you know, they pull available data, and they're able to better define the risk, which makes them more comfortable to price the risk and take it. So yes, over the last couple of decades, standard carriers and also those that are in the substandard market are taking the best risk and obviously leaving the rest for us, which is fine. But as I mentioned, that disproportionately drives up the amount that we spend on claims and our operating expenses.
So your premium has dropped, so your reserves have dropped, while
Right.
you've gotten sort of what we'd say the poorest drivers on the street.
Right. And it's also important to note that our surplus, the component of that is the investment portfolio. And obviously, you know, if you've watched the last year or so, the stock market has deteriorated significantly. So that certainly has not helped.
Thank you.
Yeah, and I'll just emphasize again, the affordability cap. So, we are providing coverage disproportionately to the poor that can't afford coverage. And again, in some communities, that's 40%. I mean, in some communities, for every dollar we collect, we pay out $1.40 with claims and operating expenses. And the one thing I know is I can't go into any of your communities and try to raise rates 40%. It just can't happen. Otherwise, the percentage of uninsured will disproportionately increase.
Thank you, Mr. Redmer. Thank you, Madam Chair.
Thank you.
Thank you. I don't see any other questions for the sponsor of this panel. I just had one. I know that we have some additional witnesses coming up that are supporting the bill with amendments. And you may not have had a chance to see the amendments because they just become available. But we would love to, after the hearing or at another time, get your feedback on the amendments that have been suggested from some of the other.
Yeah,
groups.
we've seen amendments from the Insurance Administration that we're
Okay.
fine with. The other amendments that would substantially change the bill, we would resist those, primarily because, we have in the auto industry and in the world of Maryland Auto, we've got short-term issues and we've got longer-term issues, some of which are addressed with those amendments. We want to focus on the short-term need to avoid an imminent assessment on the industry, which ultimately would be paid by your constituents. And those longer-term issues, we would prefer to work with the legislature and the industry and the Insurance Administration in trying to solve those problems throughout the interim.
Okay, thank you very much. Any additional questions? Okay, seeing none, thank you very much for your
thank you.
testimony. We'll now turn to Bryson Popham, Brett Leninger, Nancy Egan, Robert Enton, and Isadora Stern.
With your permission, Madam Chair, I'll begin.
Please, thank you.
Thank you, Madam Chair, members of the committee, Bryson Popham, appearing today in support of Senate Bill 530 with amendments, but I'll qualify that in a moment. On behalf of three clients, the agency insurance company, the insurance agents and brokers, and MAMIC, the Maryland Association of Mutual Insurance Companies. You have in your packets, to which the chair just alluded, a set of amendments. Those amendments were submitted on behalf of the entire insurance industry. This panel up here today represents the three company trade associations and agents association, individual insurers. That was very carefully put together by the industry. On behalf of my colleagues, I'm withdrawing those amendments. And we're going to suggest a different approach. While we agree with much of the testimony that was provided by MAIF, we recognize that we don't want to risk an imminent assessment. That would be irresponsible. And we are persuaded that we don't even want to take that risk. We do believe, as Mr. Redmer pointed out, that 140% loss, it's called a combined loss ratio, amounts to a 40% rate deficiency. And this will lead to the one suggestion, Madam Chair, we have for you and your committee, which could take the form of an amendment or more likely a letter from the committee to the Insurance Administration. We believe that MAIF rate making is very important. It is a subject that your regulator who works for you should be examining. They do on a regular basis. I'm talking about the Insurance Administration. But the last time a report was issued on this subject was 2004. And that report cited an average rate deficiency of 15%. We think it's time for a new report. We respectfully request that the committee reach out to the Insurance Administration and ask them to examine the subject. Thank you, Madam Chair.
Good afternoon, everyone. Nancy Egan, representing the American Property Casualty Insurance Association. My members write approximately 55.7% of the private passenger auto here in the state. And happy birthday to a certain person. And my birthday was on Sunday, my fellow Pisces. So hi. So anyway, just wanted to say, first of all, thank you to, I have to say, Al, my former boss, and the rest of the team at Maryland Auto Insurance Fund, because they began talking to us in November and December about this possible assessment and talking about ways to offset that. And one of the first suggestions was to permit the current money that's being held, that's been there since 1989 of 2.5 million to be used in any future assessments. And we knew legislation had to be ongoing. The additional funding in 17106, there has been some continuous discussion about that. And thank you again to the sponsor for holding some meetings with the Maryland Auto Insurance Fund and all the interested parties in the room in the industry to just talk about it. As my colleague mentioned, we are very happy with this idea to avoid any assessment. Obviously, my members would prefer not to have to go through that process. And we would welcome further discussion during the interim. And we would also welcome a study by the Maryland Insurance Administration just to look at MAIF rate making again because of these high losses. And with that, I turn it over to my colleagues. Thank you.
Madam Chairman, members of the committee, Robert Enton on behalf of the American Property Casualty Insurance Association. I really don't have anything to add, except we really do appreciate the cooperative spirit that we've seen with this and look forward to continuing to work with MAIF and the MIA to address these issues. Thank you.
Good afternoon, Madam Chair, Madam Vice Chair, members of the committee. My name is Isadora Stern. I'm a policy manager with Economic Action Maryland, formerly the Maryland Consumer Rights Coalition. We are a statewide nonprofit organization, and we work to expand economic equity and justice to our most vulnerable communities, our low-income communities, and our communities of color in Maryland. We do this through our direct service, our research, education, and our advocacy. We are in support of the initial piece of this bill that looks at allowing MAIF to have access to the $9.5 million in the overassessment account when another assessment is triggered. However, we do have concerns around the change in allocation of the uninsured motorist fees. First of all, we feel that the change in allocation just prolongs the need for an assessment. It feels that an assessment is imminent. We represent consumer protections and consumer interests, and we are unsure of the fear around triggering an assessment. Most other states have annual assessments. This is fairly common. The last time an assessment was triggered was in the 80s, and folks had to pay between $3 and $5, which to us, and we are representing the poorest of Marylanders, think that that is something that folks can do. Our concern is ethical around the reallocation of uninsured fines. Those are the poorest folks in Maryland. Mr. Redmer did a great job explaining the unaffordability crisis of auto insurance right now in the state. Those are folks who cannot afford auto insurance. And so in order to fund the insurer of last resort, which was created to create an opportunity for those people to have insurance, to then be funded off the backs of those poor people, we think is poor policy. If it is considered, we would also highly encourage this body to consider an amnesty program, which would help those poor people pay those fines in a more affordable manner. The last time an amnesty program was conducted was in 2019 and lasted till 2021 and allowed MAIF to collect $8 million successfully. Thank you for your time and happy to answer any questions. Thank you.
Thank you. Senator Beidle.
Thank you, Madam Chair. I think Mr. Popham, tell me a little, just briefly about the rate making issue that you have with MAIF. Do you feel they're not charging enough? What's the issue with rate making?
MAIF is a residual market mechanism. That's the term that's used in other states. And they are always under pressure for the reasons you've heard to charge adequate rates. Indeed, I think it's generally assumed that the rates in any residual market mechanism are going to be inadequate. My point, Senator Bidel, is in 2004, when the MIA reported to the General Assembly, the average inadequacy was 15%. Today, and you heard testimony at the table earlier from the MAIF representatives, it's as much as 40%. So my question is, how high can it go? You heard MAIF refer to their affordability index, and I respectfully suggest that the job of determining affordability is not with MAIF, it's with the Insurance Administration. If you read the statute, the Insurance Administration, when considering MAIF rates, has to consider the statutory purpose of the fund. That's code language for rate adequacy. So that's why we think you should reach out. But that's one reason, excuse me. We think you should reach out to the Insurance Administration and see what they have to say about it.
My concern is, we get bills almost every year about how auto insurance in certain areas, certain zip codes and locations is too high. And
Right.
if you're concerned about inadequate rates, that could only mean that the rates would even go higher. And unless we find another funding sources, which is what we're trying to do with the uninsured motorists.
I respectfully would suggest that there may be other creative approaches. And as an example, I'm not supporting this, but there is a bill on the other side. I believe it's been introduced in the Senate before that would require, I think, a $5 million commitment from the general fund for an insurance subsidy for Baltimore City drivers. That's just one example of something. I see the young lady's head nodding down at the end of the table. She's familiar with it. It's just one idea. And I want to be careful. I am not promoting that idea, but I am promoting the notion that if you get people like us in a room together, we might be able to come up with a creative solution.
So it's not just about rate making though, it's other ways to subsidize. Is that?
Well, look, the statute that was passed in 1972 that created MAIF included a provision that's there today. Like it or not, it's there. And it says MAIF is supposed to follow the rules that everybody else follows. And the most basic rule of insurance rate making, and I know you know this, is that rates cannot be excessive, inadequate, or unfairly discriminatory.
Right.
So I'm focusing on inadequate. And I'm not saying that MAIF should have adequate rates. We all know as a practical matter, that's not possible. But I would look to the insurance regulator for guidance, advice, research on that. And that is why we requested your outreach in whatever form you deem appropriate to the Insurance Administration.
Thank you. Thank you, Madam Chair.
Thank you, Senator Reedy.
Thank you, Madam Chair. And just if I could ask Ms. Stern a follow-up on what you were talking about. My understanding from this bill, and I'm trying to follow all the ins and outs, was isn't a lot of this money going to be coming from money that was overassessed many years ago?
So yes, my understanding is that this money is from the last time an assessment was conducted, which was in 1989. And the assessment was conducted, some of the private market over collected from their policyholders. That money has been on MAIF's book as a liability. They've been unable to use it. This bill isn't automatically giving them that money. What it's saying is when an assessment is next triggered, they will have access to that money before the assessment is overturned to the private market.
So why is that taking from the poorest? Because wasn't that,
So that's
I mean,
a
some of
separate-
it, maybe a piece of it was, but it was
So
1989.
the piece we're concerned about, we are not concerned about that piece.
Okay.
We think that that's fair. We would love MAIF to have access to that money. And we also like that the bill stipulates that in the future, if there is an overassessment, that money gets returned to policyholders. We think that's great policy. What we are concerned about is the reallocation. This is under the transportation article, the second half of the bill, that MAIF will now be funded from uninsured drivers, from the fines collected from uninsured drivers. We don't think that it makes sense for those drivers.
You think it should be assessed on all, it should continue to be totally assessed from.
We do. We think that by law, MAIF is intended to be funded through an assessment. It's really ironic. I'm up here with the insurance industry. They're going to disagree. We think that an annual assessment if conducted more regularly, would lower the surcharges that are being passed on to policyholders. There are also ways to change the way that assessments are conducted. If that's a concern, we can look at the way that MAPE's line item on people's policies is indicated. We can change the way that Maryland Insurance is able to pass on the surcharges to their policyholders. But that is in law that MAPE is intended to be funded through an assessment. They haven't done that in over 30 years.
Okay, just to follow up, Madam Chair, if I could ask maybe Mr. Popham to, that's not what you guys are saying. It is you represent the insurance industry.
I was nodding my head vigorously that we would disagree with an assessment
So-
broadly.
Okay, you're comfortable with that part of the bill? As it is
With
now?
the uninsured motorist piece, we had different problems with it, but we have withdrawn our
Okay,
amendment with respect to that.
all right. Thank you very much. Thank you.
Thank you. Any additional questions for this panel?
Thank you, Madam Chair, and thank you to the sponsor. Happy birthday, of course. But she has worked diligently with all the stakeholders here, and we do appreciate it, Madam Chair.
Thank you. Thank you very much. Enjoy your
Thank you.
afternoon. All right, colleagues, that concludes the hearing on Senate Bill 530. We'll now turn to Senate Bill 515, which is health insurance, step therapy, or fail first protocol revisions. Senator Lamb. And let me thank you, colleagues, for holding it down in my absence. I know a lot of you have bills in other hearings in other committees today. We were wondering who would actually be here while I was gone. So thank you all for stepping up and my bills are done. Yes. All right, Senator Lamb.
All right, like to ask folks from the sponsor panel, Ms. Kaufman and Mr. Shattuck to come up. And here to present Senate Bill 515. Good afternoon to the committee. For the record, Clarence Lamb, Senator in District 12. Those who were on the committee for, I guess it's now almost 10 years, may remember that there was a 2014 bill involving step therapy, which at the time passed without opposition in both the House and the Senate. Those provisions are now currently in statute, which you'll see in the bill draft itself. But this is an effort to bring up to date some of the provisions that involve step therapy that we have seen, particularly over the last few years, become more and more concerning. As background, step therapy is an insurance protocol or process that requires a patient to try one or more medications recommended by the insurance company themselves prior to the drug recommended by their physician or their provider. For example, I'll give a simple example here. If a physician prescribes drug A and their insurance company requires them to try drug B first and to show that drug B failed first before they could actually use drug A, which is the drug that the physician or provider intended to try to use first. So this is called fail first protocol. In other words, they have to try something to see and ensure that it fails before they can actually move on to more effective or appropriate treatment that the provider oftentimes had suggested first. The goal of this protocol, according to pharmacy benefit managers, is to reduce costs by guiding patients to drugs with better cost benefit profiles, safety, and efficacy. And while I agree that we should seek to have patients on the least expensive drug as determined to be medically appropriate by the provider or the physician, step therapy often results in delaying patient access to necessary and needed care. Data shows that step therapy protocols do not always follow best practice guidelines released by medical societies with the best expertise in treating these conditions. These protocols are also not consistent between insurance carriers, which makes it difficult for providers to justify step therapy appeals for multiple carriers. Avoiding best practices in the name of cost can compromise clinical decision-making and leads to delays in care. These delays can increase healthcare-related costs related to progression of disease because you're waiting for a longer period of time for other drug therapies to fail before they get to a drug that oftentimes providers know that work. It can lead to greater hospitalizations. It can also lead to poorer medication compliance because patients may mistrust the advice being given to them from their physician or provider because of prior drug regimens that previously failed. There are a large number of step therapy legislate bills in state governments across the country, in states that are both red and blue. Also on the federal level, the Safe Step Act was introduced by Senator Murkowski of Alaska in 2021, and it's received strong bipartisan support with co-sponsorship from almost 200 members in the U.S. House and almost 40 members in the Senate. Just to demonstrate again the broad breadth of concern from folks both at the state and federal level. In 2014, we took the first step towards reforming step therapy by requiring insurance companies to allow patients who were stable on a drug within the past 80 days to continue on that drug without having to show failure of a lower tiered drug first. This also eliminated off-label use of step therapy, requiring all step therapy drugs to be approved by the FDA for drugs to be FDA approved for the related condition. Lastly, it allowed for a standardized process for requesting exemption from step therapy protocols to be online. However, patients are still being prevented from accessing needed drugs. Under the current law, if a patient hasn't been on a drug for 180 days, they can be forced to take an inappropriate drug regardless of their physician's clinical judgment. In essence, the insurance companies are overruling what physicians and other providers already know would be most effective for their patients. This bill also takes a very important step towards ensuring patient access to treatment of serious mental illness. As this committee has heard on other bills, provider trust is really important for treating Marylanders with serious mental illnesses, such as bipolar disorder or schizophrenia. It is imperative that psychiatrists be able to stick to the treatment plan that is best for each individual patient, and therefore, fail first requirements or step therapy can be particularly harmful in the psychiatric space. Many patients with serious mental illness distrust the healthcare system already, as well as sometimes their providers. Putting these patients on a drug and having it fail first when there's already a known drug that works for them runs a significant risk of increasing that lack of trust, which can permanently result in patients discontinuing care. In current statute, there already exists a carve-out for stage 4 cancer and oncology drugs. The section regarding psychiatric drugs is building on that exemption that prohibits step therapy for metastatic cancer and oncology drugs. This is because Marylanders with stage 4 cancer and those with serious mental illness may only have one shot to help address their condition, and it's important that step therapy doesn't get in the way of the necessary care that they could receive sooner. This bill also formalizes the process of requesting exemption from fail first protocols. It will require real-time exemption of step therapy if the provider can provide proof that the step therapy drug is not indicated for the patient or would otherwise cause physical or mental harm to the patient. Step therapy would also be bypassed if the provider could prove the alternative drug is expected to be ineffective. There would also be protection for patients, switching policies, exempting step therapy if they have previously been stable on a drug that was previously covered through their own or different policies. So if they were on a policy before that covered that drug, that there would be no requirement for them to go through step therapy again just because they changed to a different insurance company. Patients who have also tried a drug in the past that was ineffective on their policy or on another policy will not have to fail a drug with a similar mechanism of action or in the same class. So if it's a similar class of drug or has a drug that's used a similar mechanism of action, if they're switching from one policyholder to another, they do not have to go through step therapy as well. Lastly, this drug will codify an appeals process for denied exemptions, which will be required to occur in real time if, number one, the criteria that are stipulated are met, and number two, if no further information is needed. So this would create a real-time appeals process for approval. Other appeals would be required to be processed within 24 hours, and appeals that aren't responded to shall be treated as granted. If payers have any of the aforementioned step therapy processes that are already in place, no further action is needed. So in conclusion, we believe this is incredibly important for patients to be able to access the medications that they need without having to jump through the extra loopholes that could lead their care astray or could cause them additional pain, suffering, potential worse outcomes or hospitalizations. Many of us in the legislature here ourselves have had circumstances or even had circumstances that we heard from constituents or have even had other family members or relatives who we know have had to go through some of these really challenging circumstances. And I think many of us have heard horror stories from our constituents ourselves as well. This bill, I think, helps address some of that and really brings up to date much needed revisions to our step therapy prohibitions that are already existing in statute. So it asks the committee for a strong consideration and favorable report, and happy to turn it over to other members of the panel and then answer questions at the end.
Thank you, Madam Chair, Madam Vice Chair, members of the committee. My name is Dana Kaufman. I'm here on behalf of several healthcare provider organizations. Last week, you heard there was a long hearing on Senate Bill 308, which dealt with prior authorization and utilization review. During that hearing, you heard several stories. One was by Dr. Chesley of a young woman who had a gastro disease. And she had to, before she was able to take the medication that he knew would be in her best interest, she had to fail on several others. In doing so, suffered medical consequences. That is what this bill is trying to address. Our law only has a 180-day look back. And I will say without hesitation that Maryland is behind the curve on step therapy. What this bill does is it gives 4 situations where a patient, on the recommendation of the physician, after having given evidence to the insurer, can skip or have an exemption to a step therapy. And again, Maryland, our law is now proven to be inadequate. I took a look at our neighboring states, Pennsylvania, Virginia, West Virginia, and Delaware, and the exact same language that is in this bill exists in those states, except for 2 provisions. And I will tell you, in those states, the health insurance industry has not fallen off a cliff. It is working and it is in the best interest of the patient. What I said last week, I will say again, Maryland has been a leader on coverage, but unfortunately, when it comes to this issue, we're not a leader in access. We think that this bill will put patients first. It has their best interest in mind. Other states have done it. And again, they have done it without repercussions to the industry. So we urge a favorable vote. Thank you.
Madam Chair, members of the committee, my name is Dan Shattuck. I'm here today on behalf of the Maryland Dermatologic Society. Speaking in support of this very important bill, thank you, Senator Lamb, for bringing it forward. I really want to echo a lot of what Dana said. This is a follow-on to the bill we heard last week and discussed. And it really is a bill that does 3 things. It improves transparency when it comes to step therapy. This bill would not only require the carriers to come up with the exceptions process, but to make it available on their website, make it easily available on their website. It's also going to strengthen the patient and provider relationship. When a physician and a patient are working on their care plan, they're coming up with what's going to work best for the patient. And that should happen without having to take consideration of, well, this is the drug you really need to be on, but you're going to have to go through these, drugs first, prove that they don't work before we can get you on the drug that really is going to work. And just to emphasize what Senator Lamb said, a lot of times patients don't have time on their side. They can't wait to fail on a drug before they get on the drug that they really need. One of our, the Dermatologist Society did an internal survey of their members asking how big of a burden this is to their practice. And not surprisingly, it came back as a very big burden. But the impact is not just them on the administration side, the time that they have to spend working with insurers and carriers to follow the various step therapy requirements, but the burden's on the patient as well. They often have to pay more out of pocket. They have to spend time again, waiting to get onto the drug that they need. And as Dana highlighted, there's medical complications to that. And they also have the stress, the emotional and mental toll it takes on a patient to get the care that they need as prescribed by their physician, only to be told no by the carrier or the PBM is harmful. So we ask for your support of this bill, and thank you very much.
Thank you. Are there questions for the sponsor of this panel? Okay, seeing none, thank you very much for your testimony. We'll call forward Lori Doyle, Josh Howe. Good afternoon. You can get started as soon as you're settled.
Thank you, Madam Chair. Lori Doyle here on behalf of the Community Behavioral Health Association of Maryland in support of this bill. We support it because it prohibits the use of step therapy for prescription drugs used to treat mental disorders. You know, the assumption, as you heard the sponsor say, behind step therapy is that many meds in the same category are just as effective, so why not use the cheap one? That may or may not be true. But when it comes to psychotropic medications, the other thing you have to think about are the side effects. And the serious side effects involved with psychotropic meds cause people to consider whether they're going to stay on that drug or not. Things like liver damage, weight gain, the onset of diabetes, sexual dysfunction, tardive dyskinesia. These are very serious side effects. To the extent that someone is put on a med that creates something that's intolerable for them, they will not stay on it. And there is a very clear correlation between going off meds, lack of med adherence, and bad health outcomes, hospitalization, loss of your job. And the decompensation for these individuals is usually very, very fast. So we ask that you take a look at this bill. Trying to get the right mix of meds for someone with a mental disorder is very complicated. So it's not just one med normally, it's a number of meds that have to work interactively. So we think this is good policy and good medicine, frankly. We thank you and hope for a favorable report.
Good afternoon, Madam Chair. My name is Josh Howe with Compass Advocacy here on behalf of the National Alliance on Mental Illness, or NAMI Maryland. NAMI believes that all people with mental health conditions deserve access to effective medication and treatment options. NAMI supports public policies and laws that reform step therapy in order for patients to receive the best medications to treat mental health conditions on the quickest timeline. Mental health medications affect people in many different ways. Individuals need to be able to access the medication that works the best for them and their individual health needs. It is important that medication decisions are carefully considered with a healthcare provider who is both extensively knowledgeable on the individual and other medication options. Step therapy can be a danger to the health and well-being of a person taking the medication and result in worsening of symptoms. Instead, NAMI asserts that policies should maintain access to provider recommended medications, or at a minimum, establish clear and rapid timelines for insurer responses to requests for exemptions, such as the language outlined in SB 15. And NAMI is very supportive of the exception allowed for mental health disorders and conditions also outlined in the bill. While step therapy is often promoted as a cost-saving strategy, policies that restrict access to medications can cause negative outcomes, sometimes leading to emergency department visits, hospitalizations, homelessness, or unnecessary criminal justice involvement. The cost to individuals, families, and communities when a person must fail on a medication before getting what they need is too high. And for these reasons, NAMI respectfully urges a favorable report on SB 515.
Thank you. I do not see any questions from the committee, so thank you very much for your testimony. We'll bring forward Matthew Celentano, Allison Taylor, Kimberly Robinson. They are signed up in opposition to the bill. Good afternoon.
Good afternoon, Madam Chair, members of the Senate Finance Committee. My name is Matt Celentano. I'm here today on behalf of the League of Life and Health Insurers of Maryland and AHIP, America's Health Insurance Plans. in opposition to Senate Bill 515 as introduced, but we are definitely willing to work on this issue as long with other issues that come to this committee. We have a few issues with the bill, but first and foremost, we want to point out that in current law, Maryland carriers must respond to an emergency drug request within 24 hours and respond to urgent requests into 72 hours. Nothing changes about that under this bill. So some specific things that we have some challenges with. On the bottom of page 4 of the bill, it reads that request or appeal must be done in, quote, real time, which assumes the providers are going through the process with electronic systems. But I think as you heard last week, we know that unfortunately, this is not reality at all. There are still a ton of providers that are providing us with snail mail and faxes. So the real time aspect of it, we just don't know if is operationally possible. Carriers were mandated by the General Assembly years ago to adopt and implement electronic systems, which we've all obviously done. Providers were not required to do so. And until they take up these or modernize their systems, we're always going to have issues streamlining the process. We are concerned also about the language that deems approval if a carrier doesn't respond in 1 day. This concern aligns with the lack of electronic communication that I just talked about. What if they're sending us by a fax? Is that going to happen in real time? Is that going to happen in 1 day? I don't think it will happen that way. There are providers who can manipulate the system without the real-time electronic means. And this is exactly what carriers are already talking about. But I just want to make sure that everybody knows that all carriers already have an exception in an appeals process. The 1 day deemed approval is just not really operationally viable. I will note in the fiscal note, it says that the extreme cost to state could result in a loss of $34 million on savings that we get through existing step therapy protocols. We ask an unfavorable report on the bill is introduced, but we are certainly willing to have discussions. Thank you very much.
So good afternoon, Madam Chair, members of the committee. Kimberly Robinson, Vice President of State Government Affairs for Cigna. Happy to be before you for the first time this year. And as Mr. Celentano said, we are also here opposed as introduced. I think that Ms. Kaufman's comment that many of our neighboring states in the years since Maryland passed its law have passed step therapy laws is true. And we worked actively in those states on those laws. And so if there was an interest in moving towards the language that appears in some of those states, which does in some very important respects differ than what's in the bill, I think that there's an opportunity there that we could take advantage of as we work on the bill in days to come. As introduced, I think Mr. Celentano highlighted several of the things that we have concern with. Obviously, we would love to be able to do all of this in real time. We are capable of it, but all of the providers that we value in our network and work with are not always capable of it on their side. And so I think that language is a little ahead of where we are in the world today to mandate real time when all parties aren't in that position. And I think that also extends to the deemer language when we're not in a real time space in particular, and things are being done by hand, they're being done by fax, things have to be filled out with all the demographic information. Something as simple as an errant member number means that we can't match that patient to their medical records to the claim. And that can slow things down, not because of any intent to keep them from a drug, but because we can't connect them to the record. And so a deemer that doesn't take into consideration if it's an administrative issue or the other things outside of just simply the company getting in and approving it makes that unwieldy to really operationalize in the real world. We are happy to continue conversations with this. I do think that there may be a place that we can reach if we look to some of our neighboring states. And with that, we ask for an unfavorable as introduced position and of course are happy to talk.
Good afternoon, Madam Chair and members of the committee. My name is Allison Taylor, and I'm here today on behalf of Kaiser Permanente. Kaiser Permanente provides healthcare coverage and healthcare services to over 475,000 Marylanders. I wanted to provide some extra context as this issue relates to the organization that I'm here on behalf of. The sponsor did reference that there are put forth the idea that there are cases where formulary design may not reflect best practices and that sort of thing. That is something that our organization takes really seriously. We have developed our formulary in consultation with the physicians that treat your constituents and our patients. And as a result of that, we have pretty strong formulary adherence. without requiring step therapy and that sort of thing. So there are multiple approaches to get at some of the issues that are raised here. That said, I did speak with the sponsor staff before the hearing, and he had some questions about mental health specifically, and I told him I'd follow up with some answers on that. So happy to continue to work on this and appreciate the time. Thank you.
Thank you very much. Senator Lamb.
Thank you, Madam Chair, and thank you to the panel for being here. I want to start with some of the things that you cited when it comes to other states that, and I look at other states that have moved towards this, and I think this was cited earlier by Ms. Kaufman as well, that other states have really moved forward with greater limitations on step therapy. And, you bring up the concern about costs, and the cost concerned in the fiscal note. I think the other thing to kind of keep in mind too is that the potential costs, and they're just citing folks that are state employees in the state system that would potentially have an increased cost to the state because of the provisions of this bill. There are actually probably cost savings that are not accounted for in here because there are these are state employees being covered. There are state employees that are not getting the medications they need on a timely basis. There are state employees that may have poor health outcomes because they're being delayed in getting the medication that they need. There are state employees that probably are being hospitalized unnecessarily if they could get their medications sooner. And so while, the fiscal note points out 34 million, I think overall, there are probably greater cost savings from not only reduced pain and suffering for patients who are, in this case, our employees. And this is just talking about state employees. It has a broader reach as well to everyone that's covered under health insurance. But this is not accounting for those cost savings. And when you look at other states like West Virginia that have done this, and they have not seen the bottom fall out with their insurance market, I question why, the cost savings aren't there for this and why you cite that so heavily.
I'll take that. DLS is not able to score potential savings in their fiscal notes because it's more uncertain to be able to do that in a scenario like this. So I think that's why those certainly defer to committee staff for that discussion.
Great, well said. But I think just to bear in mind for folks, the 34 million cited in the fiscal note is really kind of a one-sided, as Ms. Taylor was mentioning, a one-sided kind of prediction of where those costs may be incurred. The other piece too is I know there's a lot of reference to an IT system, but to the best of my understanding, every one of the carriers has their own type of IT portal to input this information into. Is that correct? There's not a single portal for a provider to go to be able to enter their patient's information for an exemption. Is that right?
So thank you for the question, Senator Lamb. I'm going to answer it with two things. One, if the provider is not on their side using a real-time benefit check or other electronic EMR system in their office that can connect, they may be going individually to each carrier system. Many of the systems on the market for use in the provider's offices, however, are designed that through that single entry that the provider is using, it can connect to all of the carriers. So it just depends on what technology the provider has chosen to invest in.
Okay. But most providers have to move to an electronic medical record now, a lot of times because of incentives that the federal government and Medicare and Medicaid have too. And so they're using their own electronic medical record systems. And you're saying that some of the carriers may not have the interface directly into their EMR?
My understanding is we all do. It depends on what EMR the provider selects. They may make so there's a range of things available on the market for the provider, and they make choices because you can choose whether or not you're just doing medical records, if you're doing something that allows your system to talk directly to the carrier system, if you're doing something that includes real-time benefit check. So there's a variety of choices that may be made in the office. And you're right, a lot of providers have made tremendous progress towards the adoption of electronic systems. All providers have not. It certainly has increased since this body mandated that carriers have them, but we're still not at the full adoption yet. So when we talk about the real-time language, our point is to say that it has no exception for those providers who are not able to help facilitate the real-time process in their office. It's different for those who can, but the bill is written to assume everyone is capable of it. And we're just here to show that that's not the current situation.
Okay. All right. No further questions, Madam Chair.
Thank you. Senator Mounts.
Thanks. And it's been very interesting testimony. And I thought I understood it. And I heard more things. I got a little twisted and confused and I started sorting through the testimony. But I wanted to ask from the perspective of the carriers, wouldn't having the step therapy cost more if the patient is having to do multiple courses to get to the medication that is originally being pursued by the doctor or the patient? Wouldn't that benefit the carriers for not having to prescribe more medication?
Sure, arguably, yes. I think that the challenge we're having in talking about this bill is having the line of sight into all of the prescriptions that we're covering under step therapy and how often that's the case, looking at all of the prescriptions and the experience of the proponents, which is absolutely valid, but is from their individual perspective, right? They don't have the breadth of prescription experience that we have, only because we can look across the whole client, across the whole state, across the whole country. So yes, I think that for those examples where someone has found themselves having to move from drug to drug, which sometimes happens because of step therapy, sometimes happens because it's just not the right drug, has nothing to do with step therapy, that's always going to be the case. I think part of the question is what's the broader cost implication of that? I think that there's an assumption that we're forcing everyone to fail, and that's not what's happening.
Right. But in the way the bill's proposed and conceptually looking at this, it could be a benefit to the carrier side of the discussion. I understand the complexities. I'm still learning about the complexities and that sort of thing. But if that were to be an end result, would that be a benefit?
Sure. And I'll say this, Senator Mounts, as we said, there are certainly some of the states that have already been cited here today who have laws that our companies have worked on and that we don't have any quarrels with. This bill aligns with some of those pieces. Some of the language is exact, some of the language is not. Some of the pieces here exceed and differ from those laws. So I think that's the conversation we would like to have with the proponents outside of the hearing, because I think the closer they come to the states that they're holding up, the more we're going to find agreement on what some of these pieces are.
Yeah. Well, thank you very much.
Okay, thank you. I don't see any additional questions. Thank you very much for your testimony.
Thank you.
We do have virtual witnesses signed up in support of the bill. We'll go first to Sharon Long. Good afternoon.
Good afternoon, Chair Griffith and members of the Senate Committee. My name is Sharon Long. I live in Fort Washington, Maryland, and I have multiple sclerosis, a chronic disease of the brain, optic nerves, and spinal cord. MS has significantly impacted my spine in that I have difficulty walking and standing. I have come to you to ask you about this therapy to favorably pass SB 515. I was officially diagnosed the day before Thanksgiving, 2018. And my family and I, ever since then, have been trying to think outside the box of how we're going to do things on a daily basis. So if you don't mind, I'm going to take you into a doctor's appointment with me. I want you to come into the appointment where I and my doctor are talking. We're getting a medication that works for me, works for my MS. And in comes an insurance representative who has not taken an oath not to do me any harm and takes the prescription away from my doctor, saying she can have this after a year of trying this alternative. I take the alternative, and throughout that year, I get sicker and sicker and develop other health issues I did not have before. Then you give me the drug back, and it doesn't work anymore. And now I have additional issues. Well, in the meantime, you've made me a guinea pig. And while you're doing that, the insurance company is getting paid hand over fist for the original drug, the alternative drug, and anything else now I have to take to get myself back to a new norm for my MS. I'm representing everybody in the MS community. We are not guinea pigs. We are people that are going into the society, giving into it. And I'm asking you to consider, please, to favorably pass this bill. It's MS today. It could be diabetes, high blood pressure, and anything else tomorrow. Thank you for listening. Please favorably pass it.
Thank you very much for sharing your story and your testimony. I don't see any questions, so have a good afternoon. We're going to turn to Shannon Wood. Good afternoon.
Good afternoon, Madam Chair. Thank you. I am here on behalf of the National Multiple Sclerosis Society, and we support SB 515. Multiple sclerosis, or MS, as Sharon just mentioned, is an unpredictable disease of the central nervous system. Symptoms vary for each person and can include disabling fatigue, mobility challenges, cognitive and vision issues. People with MS and their providers have voiced concern regarding the potential harm of step therapy protocols when not paired with proper patient protections. Step therapy protocols transition medical decisions from a shared decision-making approach towards more standardized policies that might not consider detailed conversations between providers and patients as they discuss the right medication for each person, taking into account things like efficacy, dosage, route of administration, and side effects. The therapy that works for one person with MS might not work for the next person. When patients must cycle through and document a step, or in some cases multiple steps, the process can result in substantial delays in treatment deemed appropriate by their provider. This process may affect a person's ability to immediately start treatment, or in some cases, their ability to continue a treatment that's been effective for them. Prolonging ineffective treatment may result in disease progression, which for those with MS can be severe and disabling. Evidence shows the initiation of treatment with an FDA-approved disease-modifying therapy as soon as possible following an MS diagnosis. It can take years to find the most effective course of treatment. And once the patient finds that course of treatment that works for them, they should remain on that drug uninterrupted. Considering the cost of MS medications, patients cannot afford to take drugs out of step order and without coverage. Last year in 2022, the median annual price of MS DMTs was close to $94,000 per year. With that, I'll conclude my testimony by saying that the National MS Society respectfully urges this committee and the larger legislative body to pass SB 515 this session, and we thank Senator Lamb for bringing it forward. I'm happy to answer any questions that you may have.
Thank you. I don't see any questions, but we appreciate your testimony. Thank you very much. We'll now call on Chisana Kindred. Good afternoon.
Good afternoon. Thank you for the opportunity to provide testimony in support of SB 515. I'm Dr. Shoshana Kindred, a board certified dermatologist from Columbia, Maryland, and I'm representing the Maryland Dermatologic Society. The most common cancer in the US is skin cancer. Dermatologists diagnose and treat more than 3,000 diseases, including skin cancer. The problem is insurers invoke step therapy protocols between 5 and 20 times per month, causing 5 to 30 hours plus per month of our time to respond to step therapy protocols. I see fewer patients every day so that we have enough time to address the treatment denials from insurance companies, figure out the step therapy protocol, change the prescription, and then call to explain it all to the patient. Patients don't like step therapy. They respond with comments like, how does the insurance company know what I need? They weren't in the room with the doctor and me. Dermatologists don't like step therapy. They refer to prescription pads now as just suggestion pads because the insurance companies often come in and change it. When we testified in support of step therapy reform in 2018, the committee members asked us to return if we had examples of how the law is not working. Our society surveyed its members. The vast majority indicated that directly because of step therapy, patients pay more out of pocket for their medications. And we've also noted, the majority of us, that the rates of non-adherence to treatment plans has actually increased. As physicians who are on the front lines treating skin cancers, fighting skin diseases, the Maryland Dermatologic Society believes that Senate Bill 515 will strengthen existing laws, will benefit our patients, ensuring they have access. Thank you.
Thank you. And I don't see any questions, so thank you very much for your testimony. We'll now turn to Louis Tharp.
Good afternoon. Good afternoon, Madam Chairwoman and committee members. My name is Louis Tharp, Executive Director, co-founder of the Global Healthy Living Foundation, and I'm commenting on behalf of chronically ill patients in Maryland. Thank you for allowing me to be here to support Senate Bill 515. I spoke last week in favor of SB 308, the prior authorization bill. Senate Bill 515 puts the patient first by regulating an often damaging utilization review practice regularly used by pharmacy benefit managers and health insurers to control their costs. It's called Fail First. We prefer patients to succeed first. The patients GHLF represents are among the millions who are subjected to unnecessary barriers by insurance companies in their quest to increase profits, not, as insurers often say, to lower drug costs. The patient does not experience a lower cost when they fail first. In addition, oftentimes patients have to fail up to 5 times before they're finally given the prescription their doctor prescribed. The duration of this protocol is left up to the insurance company, and it can run 130 days or more. Using Fail First, insurance companies can delay or even override a treatment plan created by a doctor and patient to the point where permanent, irreversible damage can occur. Senate Bill 515 is about patient protection. It guarantees that healthcare protocols are implemented in the patient's interest, not the profit motives of private companies with opaque operations. When you vote, please consider that under the current system, people living with chronic illness face undue suffering while insurers and PBMs enjoy additional profits.
Thank you. I see no questions from the committee, so we thank you for your testimony and your time. We're going to turn to William Roberts. Good afternoon. We cannot hear you. It looks like you're speaking. Still can't hear you.
Hello, can you hear me now?
We can hear you now. Thanks.
Okay, sorry about that. Good afternoon, Chairwoman and esteemed members of the committee. My name is William Roberts. I'm a second-year resident at Johns Hopkins, specializing in internal medicine in the primary care track. I'm not here in representation of Hopkins. I'm representing myself as a frontline provider here in support of Senate Bill 515. As you have heard, the idea of step therapy is thought to, preserve costs, also preserve the safety of the patient, and is said to be evidence-based. But this is not something that we on our end, on the provider, agree with. This is actually confusing for a number of us. First of all, because these protocols, they vary in between providers, and additionally, though they vary, they don't match clinical guidelines that are given by organizations. So we find ourselves a lot of times having to practice outside of clinical guidelines, which is, in our opinion, causing harm to patients, also to us in our society. As many others have mentioned, this is harming our patients due to delays in care, also disease progression. I'd also argue that a lot of these guidelines don't take into account the benefits that these patients can have when preventing, disease down the line. We see this a lot with cardiovascular disease, with a lot of higher tier drugs that have benefits in kidney and cardiovascular disease reduction. I also want to bring up the fact that this state has a state of the highest emergency department waiting times in the state and poor ambulatory metrics. These delays in care can worsen the morbidity of our outpatient population, worsening the pressure that is seen on our medical society. Lastly, I want to bring up a recent study that's shown that primary care doctors need 27 hours per day. They're found to need 27 hours in a day to give care that's up to guidelines. A lot of this care that is causing these increased stress on providers is due to the paperwork that we're having to provide in the form of these step therapy and telehealth. So I would urge for this balance to be shifted more towards the provider, because every single failure, every single fail first is a patient. Thank you.
Thank you. No questions from the committee. Thank you for your testimony. We'll now hear from Melissa Horn.
Thank you.
Good afternoon.
Good afternoon. Thank you. My name is Melissa Horn. I'm the State Legislative Affairs Director for the Arthritis Foundation. And I want to thank the chair as well as the members of the committee for their consideration. So on behalf of more than 1.4 million residents in the state of Maryland with doctor diagnosed arthritis, step therapy can really be a burdensome process that can pose a significant hurdle for patients and impede patient-centered care. So we actually did a survey of more than 1,400 patients recently, and it revealed that over half of all patients reported having to try 2 or more different drugs prior to getting to the one that their doctor originally ordered. Step therapy was stopped in 39% of cases because the drugs were ineffective, and 20% of the time due to worsening conditions. Incredibly, nearly a quarter of patients who switched insurance providers were required to repeat the same step therapy with their new carrier. So the complexity, the length of the processes, this leads to delays in treatment and can actually increase costs, but also really be worse for the patient who can even become permanently disabled. Arthritis is the #1 cause of disability in the United States. So streamlining step therapy tools to allow for flexibility, including timely override of requirements, appeal of denials, and in circumstances where a patient is changing plans, ensuring that the new plan does not repeat the same process is really invaluable. So we really truly urge the committee to pass favorably this legislation, as it can take months or even years to find a treatment that works for patients living with arthritis. So thank you so much for the time to testify today, and I'm here for questions.
Thank you. There are no questions from the committee, so thank you very much for your testimony. And colleagues, that will conclude the hearing on Senate Bill 515. We will now turn to Senate Bill 534, which is Preserve Telehealth Access Act of 2023. Senator Guile, and if you have a panel, feel free to bring them forward.
Yeah. One more. Yeah. Yep. And also, okay. Good afternoon, Madam Chair, members of the Senate Finance Committee. For the record, Senator Dawn Guile here to present SB 534. I would note at the outset, colleagues, this bill, SB 534, Preserve Telehealth Access Act of 2023, was included in the bipartisan behavioral health legislative package that some of you may have seen notice of the press conference that we held last week. So this is one of a priority among those bills. So during the COVID-19 pandemic, telehealth was the only option for many Maryland patients and providers to deliver routine health care. Thanks to emergency federal and state waivers, during the declared public health emergency, the use of telehealth ramped up quickly. During the 2021 General Assembly session led by Chairwoman Griffith, we passed the Preserve Telehealth Access Act of 2021 to codify many of these regulations. This landmark legislation allowed healthcare providers to continue delivering safe, reliable care via telehealth at the right place, the right time, and the right modality for patients. The bill permanently removed originating and distant site restrictions and expanded remote patient monitoring coverage for Medicaid patient or participants. It also allowed providers to continue using audio-only means, such as a standard phone call, to deliver appropriate healthcare services, and required reimbursement parity, meaning services delivered in person and those delivered via telehealth are to be paid at the same rate.
However, the continuation of audio-only telehealth services and reimbursement parity flexibilities were slated to sunset on June 30th, 2023, so later this year. Senate Bill 534 continues the success of the original Preserve Telehealth Access Act by extending these flexibilities through June 30th, 2025. I would also note that I've requested an amendment to require the Maryland Healthcare Commission to submit a follow-up study to the report required under the 2021 legislation. So if you note inside the bill packet, not a single unfavorable, but everything was favorable and favorable with amendments. That amendment was to require the study to be conducted. The changes made in 2021 are critical, not just for care delivered during a once-in-a-lifetime pandemic, but also for providing access to needed care to all Marylanders from the Eastern Shore to Western Maryland and everywhere in between. As one of the providers represented by one of the many organizations supporting this bill reported, we treat a lot of patients. If they are poor, if they are old, we may not be able to find out what's going on with them without a phone. In other words, telehealth can often be the difference between a visit to a healthcare provider or no care at all. The legislation is a measured approach to continue current telehealth policies while fully understanding the role of telehealth in our healthcare system. And I respectfully request a favorable report.
Thank you. Thank you, Madam Chair and members of the Senate Finance Committee. For the record, Erin Dorian, Vice President of Policy for the Maryland Hospital Association. I want to thank Senator Guile for building off of the chair's good work in 2021 and sponsoring this very important piece of legislation. We are very proud that you can see all of the stakeholders here today in support of the bill, agreeing to extend the flexibilities for 2 more years while MHCC can conduct this final study. You'll hear from David in a second where he'll talk about what the study will do, but we believe that this study in these next 2 years will allow us to look at the role of telehealth in our healthcare system as we move forward and allow patients and providers to continue the important care relationships that they have built. The hospital field looks forward to working with MHCC, payers, and the other stakeholders over the next 2 years, and we urge a favorable report on SB 534. I will also say, as the omnibus behavioral health bills move forward, we will be putting this study on those 2 pieces of legislation as well. So we will be seeking amendments to make sure that all 3 bills conform together. But we believe that telehealth is such an important topic and something that should move forward on its own. Thank you very much.
Good afternoon. Good afternoon, Chair Griffith and members of the committee. For the record, my name is David Sharp. I'm the Director for Center for Health Information Technology and Innovative Care Delivery at the Maryland Healthcare Commission. It is a pleasure to present our testimony on behalf of our Executive Director, Mr. Ben Steffen, who was not able to be here today and sends his regards. The Commission supports Senate Bill 534 with amendments. Chapter 70 and Chapter 71 of the 2021 laws of Maryland temporarily expanded through June 30th the definition of telehealth to include medically necessary somatic, dental, and behavioral health services and removed restrictions on location to patients. The law requires audio-only telephone conversations between a provider and a patient to be reimbursed at a rate covered healthcare services delivered in person. The bill extends coverage and reimbursement provisions in the Act through June 2025. A key element in the report that MHCC presented to this body on January 24th is the study component that you've heard the Senator and Ms. Dorian note. Allow me for a moment just to highlight the elements so give you a better understanding of what the amendments will do. The amendments will look at questions such as, does it cost more or less for providers to deliver telehealth? Does telehealth require more or less clinical effort for a provider? Are there aspects of telehealth that yield lower value, overuse, or conversely greater value that inform the debate on payment parity? The adequacy of reimbursement for behavioral health services delivered in person and by telehealth. And lastly, any covered findings and recommendations that weren't previously noted. We plan to have this report made available to the legislature to help inform legislation during the 2025 session. We hope this information is helpful and encourage a favorable report on SB 534 with the proposed amendments. Thank you, Chair Griffith and members of the committee.
Good afternoon, Chair Griffith and members of the committee. My name is Allison Taylor. I'm here on behalf of Kaiser Permanente. My colleagues and the sponsor presented this perfectly already, so I'll just say me too and urge a favorable report.
Good afternoon, Madam Chair, Madam Vice Chair, members of the committee. Again, my name is Tricia Swanson, and I'm Acting Director of Government Affairs for CareFirst Blue Cross Blue Shield. I won't repeat what's been said. I'll just add that CareFirst recognizes what an important component telehealth was and how it served as an invaluable lifeline during the pandemic in meeting patients where they were. Telehealth continues to evolve, and addressing the lack of available data measuring the impact of audio-only and audiovisual technologies should remain a key focus. It's imperative that the MHCC continue to gather more information that supports the development of evidence-based coverage and payment recommendations. We strongly support the policy goals advanced in this bill and the proposed amendment. Increasing access to affordable, high-quality healthcare is central to our mission at CareFirst, and we stand ready to support and assist the MHCC in their work. Thank you.
Madam Chair, once again, I'm Matt Celentano here today on behalf of the League of Life and Health Insurers. I'm really just happy to be here to support something. But I will say that carriers have been required to reimburse for telehealth since 2014, but not a lot of people are using it. And unfortunately, it took a global pandemic for that sort of to change. We went from utilization in the teens to during sort of the safer at home measures, 80% of healthcare was being delivered through telehealth. That utilization has gone way back down, but we are also looking at a new normal. And I think with the inclusion of the study to be able to figure out what that new normal is going to look like, we can figure out the proper approach. We thank you, Madam Chair, for bringing the bill before, and we thank Senator Guile for bringing this bill, and we are favorable with the inclusion of the study. Thank you.
Thank you. I think we covered everyone on the panel. So Senator Lamb.
Thank you, Madam Chair, and thank you to the panel. I just have one question. I'm very supportive of the bill and the provisions there. And I question, the question stems from the fact that we've also heard from a lot of providers that feel like this is real, the provisions in here are really, really important. And that's why we have to pass an extension of this. But given the fact that it's a new norm, right, that's been kind of brought up, why is this bill set as a sunset as opposed to simply, putting this into statute? And then when the study comes back from MHCC in 2025, looking at what we need to do to tweak it or update it. The way that it's coming in the posture that this is a sunset, which means that, kind of leaves this lingering as something that, could be taken away again at some point in time, where I think we all recognize this is the new norm. This is now, an important part of how providers can practice. I'm just curious why this is still coming in as a sunset in this way then.
David, do you want to add there?
I'm happy to give it a start. Senator,
Go ahead.
So, the great question, Senator Lamb. A little bit of background. The sponsors of the bill mirrored largely what the 2021 Preserve Telehealth Access Act, and in that it's sunset based upon a report. So using that as the framework, the idea was to extend, as I understand it, to extend the date in the statute to allow for the study that would be then used to inform actions of the legislature, as opposed to just assuming it would be perpetual, but using a study to really base it on empirical evidence. And I get that, but 2021 is a very different place than where we are in 2023 as well. And so, I'm just wondering, because at 2021, we were still kind of working our way through a lot of this, and this new norm was still kind of being established. Now, I think all of us agree telehealth is here to stay. This is the new norm. It just seems a little bit kind of unnecessary hedging of our bets, because it puts the onus back on coming back to extend it again, when I think we all recognize this will be an established part of how medicine's practiced moving forward, and understand that there's a study that's still coming back, but it just seems like the paradigm's a little bit flipped here. Fair point.
Senator Lamb, thank
gonna
you for the
disagree.
questions. If you don't mind, Madam Chair, do you mind? Okay, thank you. I think there is nobody at this panel or probably behind us that would suggest that even after the sunset of this bill, if it is does pass, that anybody wants to take away the coverage access issues. I think those are here to stay. That's not going away. I think those will be permanent. During the discussion in 2021, one of the reasons that we all agreed to study parts of it was we don't know exactly what's appropriate that should take place in telehealth visits, what not. We've seen a lot of research that shows that the medical effectiveness of in-person visits is better than telehealth in some aspects. We're also still learning. We also thought when we passed the bill in 2021 that hopefully we would be through the pandemic by now. As you know, we still see higher utilization rates than we saw before, and it hasn't settled back down to get the proper amount of data to figure out how we approach it in the future. I think that most of those discussions will happen on the payment side. I don't think it will have anything to do with the access side, but I think that's why the study is appropriate to finish that discussion that we started in 2021 that we haven't had a chance to finish.
Sure. And I guess my point being then is just if we want to reassure folks on the access side, one approach could be to apply this without the sunset, and then we can come back and address the findings in the study, but understand. So thank you, Madam Chair.
Thank you, Senator. I don't see any additional questions. And let me just thank you, Senator, and thank you to the panel. It is nice to see a consensus piece of legislation on this subject that I did not sit in 45 meetings. So thank you all very much. All right, we do have some additional witnesses signed up on the bill. We'll start with Lori Doyle, Shruti Police, Helen Hughes, Michael Patty, Ellen Weber signed up in support of the bill. And then I also have Steve Weiss.
Thank you, Madam Chair. Lori Doyle on behalf of the Community Behavioral Health Association of Maryland. And it really is nice to see the witness table with carriers and providers all agreeing. What a wonderful thing. This is a great bill, and I think it's a testament to the bill and how strong it is, and also to the testament of what you all did in 2021. That was a great piece of legislation. The two things that were most critically important to behavioral health providers and the people we serve were the two pieces that were up for the sunset. So the audio only and the rate parity. The audio only because we serve indigent people who often don't have access to the technology for video technology and telehealth. And also they live in rural areas where broadband is spotty at best. The rate parity issue because we are struggling to keep our workforce as it is with our rates. And if the rates were cut for telehealth utilization, we'd probably have to eliminate it. And that would be hard on the folks we serve who have challenges with transportation and inflexible work schedules and childcare and the rest. So we thank you for what you've done with this from 2021 and today. And we hope you will support the bill. Thank you.
Michael Patty here in support of Senate Bill 534. I don't need to make any new arguments. I just want to highlight that we submitted a lot of written testimony for a number of clients. I just want to recognize them because they're not here today. I'm here for them. The Maryland affiliate of the American College of Nurse Midwives, the Licensed Clinical Professional Counselors of Maryland, the Maryland Assembly on School-Based Healthcare, the Maryland Community Health System, the Maryland Dental Action Coalition, the Maryland Nurses Association, the Maryland Occupational Therapy Association, and Movable Feast all support this bill. And we're looking forward to the next 2 years and the study by MHCC.
Chair Griffith, Vice Chair Klausmeier, and members of the Senate Finance Committee, thank you for this opportunity to testify in support of Senate Bill 534, and a special thank you to Senator Guile for being the lead sponsor on this bill. My name is Shruti Police, and I'm an intern for Maryland's Healthcare for All Coalition, and I'm presenting this testimony today on behalf of our individual organization, Maryland Citizens Health Initiative. Our organization's mission is to ensure that all Marylanders have access to quality and affordable healthcare coverage. And one of our top priorities is health equity for vulnerable and underserved communities in the state. This bill would extend until 2025 the inclusion of audio-only telehealth in the definition of billable telehealth. Many Marylanders, especially vulnerable and underserved populations, rely on telehealth to continue to receive the care that they need. Audio-only telehealth is especially important because of disparities in access to technological resources. Over 500,000 Maryland households do not have reliable broadband internet at home, and close to 300,000 households do not have a desktop, laptop, or tablet. Therefore, Senate Bill 534 would help to protect equitable healthcare delivery gains in Maryland. We thank the committee for its leadership in passing the original Preserve Telehealth Access Act in 2021 to include audio-only telehealth. Thanks to you, Maryland has one of the top 5 healthcare systems in the nation, and Senate Bill 534 will continue Maryland's leadership. We urge the committee to give a favorable report for Senate Bill 534. Thank you.
Madam Chair, members of the committee, thank you for having me this afternoon. My name is Dr. Helen Hughes. I'm the medical director for the Johns Hopkins Office of Telemedicine and a general pediatrician practicing in East Baltimore. And I'm here to express my support for SB 534. I'm very grateful to the leadership that led to the passage of legislation in 2021, as well as this bill, that I, as a pediatrician, a parent, and a patient, have the ability to use these telehealth tools and want to make sure that these tools remain accessible to all patients. Of the 2 goals in the bill, I'll speak briefly about audio-only telehealth, data from our institution. You have our written testimony with more details. Last fall, my colleagues and I published a paper describing how audio-only telehealth has been an important access point at our institution, Johns Hopkins, particularly for patients who have faced barriers to receiving video-based telehealth, including those who are Medicaid enrolled, older, and have limited English proficiency. At our institution alone, if you take out the first year of the pandemic and look since July of 2021, we've delivered almost 80,000 audio-only visits to patients across Maryland in specialties ranging from primary care to behavioral health. And outside of primary care and behavioral health, our most common subspecialty has been oncology. But we have disparities in the distribution of these audio-only visits. Of telehealth visits with privately insured patients, 7% have been conducted by audio only, compared to 28% of visits with patients insured by Maryland Medicaid. And these disparities have unfortunately persisted, even if you look at the past 3 months. So we are very supportive of continuing audio only and parity reimbursement for telehealth and urge a favorable support of SB 534.
Thank you, Madam Chair and Vice Chair and members of the committee. I'm Ellen Weber. I'm with the Legal Action Center, and we convene the Maryland Parity Coalition, whose mission is to expand access to mental health and substance use disorder care. The continuation of audio only and payment parity in both public and private insurance is really a priority of the coalition's members, both the consumers and the providers, because these have expanded access to mental health and substance use disorder care significantly. Members of the coalition participated actively in the MHCC study, and their experiences are borne out by the report. Basically, the vast majority of mental health and substance use disorder providers used telehealth during the pandemic, and they want to continue to do that. And both audio only and audio visual improved access to care, particularly among people who face barriers based on transportation, technology, and stigma, and also those who have employment and family responsibilities. Audio only is not only effective, but pending infrastructure development, it really is essential to ensure equity for rural, older individuals, lower income, non-English speaking individuals in the Black and Brown communities. So continuation of audio only is also needed to allow Marylanders to take, with opioid use disorders, to take advantage of what we expect will now be the federal standard for initiation of medication for opioid use disorder treatment. The Department of Health and Mental Hygiene just recently issued proposed regulations that will allow buprenorphine to be prescribed using both audio only and audio visual on a permanent basis. But to ensure that these paths to recovery are available for all individuals in Maryland, payment parity is required. The provider effort and the cost for all modes of telehealth is the same as for in-person services. But as the MHCC study found, low or no reimbursement for audio only will result in care in providers discontinuing that service. And finally, we are very pleased that the bill will preserve a consumer's choice on how they will receive access to mental health or substance use disorder care, whether in person, by telehealth, or a hybrid. Thank you very much, and we urge favorable report.
Thank you. I don't see any questions for this panel. Thank you for your work and collaboration and your testimony. We have one virtual witness signed up on the bill. In support of the bill, Dr. Tamara Green. Good afternoon.
Oh, good afternoon.
Madam Chair, and my name is Tamara Green. I am the Chief Medical Officer for Baltimore City Health Department. And I would like to say thank you for this opportunity. As many of the panelists have already mentioned, we are in support of telehealth for various reasons. And we know that during the pandemic, telehealth services were able to fill very vital healthcare gaps by increasing access to care for many patients. According to CDC data, 37% of adults aged 18 and older used telehealth services during 2021. The adoption of these services increased many benefits such as convenience, shorter wait times for appointments, and slowing the spread of the disease by eliminating exposure to other patients as well as staff members. And looking forward, we believe that telehealth will continue to provide increased opportunities to people who receive healthcare in a safe and equitable manner. In particular, telehealth can be a more accessible option for those who live far away from providers, such as in rural residents, residents with mobility issues, as well as people without access to transportation, and individuals who are immunocompromised. And we believe that telehealth can also be cost-saving for Marylanders, as it will eliminate the need for childcare, reduce time away for patients, time away from work, as well as eliminate transportation costs. So we respectfully request support a favorable report for Senate Bill 534, as it extends the reimbursement and coverage of telehealth services by the Maryland Medical Assistance Program and other insurers within the state. And again, thank you so much for this opportunity.
Thank you for your testimony. There are no questions for you from the committee, so have a good afternoon.
Great.
And colleagues, that concludes the hearing on Senate Bill 534. We'll now turn to Senate Bill 412, which is the Transportation Maryland Rail Authority Establishment, Maryland Rail Investment Act of 2023. Senator Rosapep, Mr. Vice Chair, good afternoon.
Thank you. It's nice to be back so soon. Unfortunately, this is also a slightly big bill with some complications for which I apologize in advance, but it's also very important, and I'm pleased to be sponsoring and presenting it. It deals with a number of things that are of concern to all of us. One is climate change, one is economic development, and one is the state's ability to invest in our transportation infrastructure. What the bill does is it creates a Maryland Rail Authority that would have the ability to, in an integrated way, plan for the expansion of our rail capacity in the state, the way other states do. We've seen how Virginia's gotten ahead of us in many ways. There are several other states, New York, New Jersey, and Pennsylvania, that have equivalent rail authorities to what's proposed in this bill. So partly it's a planning function, but more importantly than that, it's a fiscal function. So the authority would have the ability to work with the Maryland Transportation Authority to identify what's called optimal pricing for tolls in the state that is defined in the bill. The idea essentially is that well, at least I think of people paying tolls as when I go to Ocean City. The reality is most tolls are paid by people in commerce coming through Maryland, going north and south on I-95. And it's largely trucks, but it's also others. That's where most of the toll revenue comes from. We have not had an optimal pricing structure over the years. And over the past few years, when there have been reductions in tolls, they've accrued to everybody, not to the local residents. So what this basically says, it's what other states do, is come up with an optimal tolling strategy that maximizes the amount of money we collect from those who are not our folks and who are passing through, and we're providing the infrastructure for them. And then recycle that money, and they do this in the other states, into building the rail structure. So it's a win-win from a transportation point of view. Obviously, you need to keep enough money in the Transportation Authority to have good maintenance on the toll facilities. But the excess would be transferred to the Rail Authority. The estimates, they're rough estimates at this point, that it could generate $200 to $300 million a year, which then the Rail Authority could use to issue bonds to invest in priority rail projects. And the bill identifies initial priority rail projects. And you'll be glad to know, Senator Ellis, that one of them is the Southern Maryland Rail Project. And any of our friends here from the city of Baltimore. It includes the Red Line. And for most of us, it includes MARC, which serves people in various parts of the state. So those are identifying the bill's initial priorities. He would set up a 9-member board of directors to oversee it, chaired by the state secretary of transportation. So it's not like a rogue agency. It's part of the transportation department that in that sense, but fiscally, it has its own revenue source. That's essentially what the bill does. There are lots of details and lots of legal technicalities, but that's the essence of it. Happy to answer questions.
Thank you very much. Are there any questions for the sponsor? Senator Reedy?
Thank you, Madam Chair. Thank you, Mr. Vice Chair. So when I first saw this, I thought, oh no. But then I was trying to be sure I, wasn't just seeing the wrong things that you would not want me to see. So
I'm fully transparent.
what would Maryland Department, what would MDTA do if we take away rail? Would they handle
that's addressed in the bill, that they would negotiate that out, that it could be the rail agency would do operations as well as planning and financing, or they could have the MTA do operations. It's flexible, it's set up flexibly in the bill.
And you said, so you talked about how you could get other people coming through our state to pay more
fair share.
How does that work?
The way it works is that you obviously do a study to figure out what the optimal rates would be. And then you can provide exemptions, isn't the right word, a different rate for people who live here, a different rate for people. We have this issue over near Dundalk, Senator Sallings always talks about, in terms of people making very short transitions, trips. You can customize it so that where the big money is, you're collecting the big money, and we can use it to improve our economy, improve our climate, include our transportation, but you can protect local folks. That's essentially the way it works.
I guess I thought that would violate some sort of interstate commerce.
Evidently, it doesn't. They do it in other states.
Okay. All right. Thank you, Madam Chair.
Thank you. Senator Mounts.
Just a quick question. So the fees,
tolls,
I'm sorry, the tolls, right now they go into the Transportation Trust Fund?
No, they go into the Transportation Authority. They have a separate bank account.
And what do they fund right now?
Right now, they fund maintenance of the toll roads and a surplus.
Okay. And then this would take some of those fees and apply them to the rail.
Yeah, it would keep enough in there to maintain the toll roads in good condition. So you wouldn't go below what you need to keep in good condition. Right. But it basically says that we can have higher pricing for the tolls for the folks who are coming through the state and taking advantage of our infrastructure, and use that to recycle to create more rail capacity, which frankly is good for everybody. Right. Because when you get folks off the roads, get them in the train, that helps people on the roads too.
Thank you.
Thank you.
Thank you. Senator Ellis.
Thank you, Madam Chair, and thank you, Senator Rosapep, for this bill and for thinking about Southern Maryland Rapid Transit. We always appreciate that. So driving through upper Northeast, New York, Connecticut, they have this variable pricing structure. I went through there, I do believe, right?
Yeah. I'm not sure Connecticut, New York, New Jersey, and Pennsylvania.
Yeah, and it's not just for trucks. I remember as in my car, if you have a New York, I think, yeah, you're right, New York, Easy Pass, there's one rate.
Exactly.
Easy Pass from out of state.
Hard rate for Marylanders.
I'm sorry?
It's the hard rate for Marylanders, not the easy one.
The hard rate?
The opposite.
No, okay, well, anyway, we'll talk about that later. But
just joking.
I missed that. But I was quite, upset about that. I wish I could vote in New York to kind of vote those folks out who put that in there, but I'm in Maryland. So you said this would just affect like the trucks passing through like with higher rates?
No,
or
not
would it be like
not just
New
trucks.
York?
The details will have to be worked out. And that's why this is the first time this bill's been introduced. I think the committee needs to dig into it and do in the other house as to in detail how it works in other states. There are probably different ways of doing it, and we'd have to craft it in a way that we felt most comfortable with.
Okay, thank you. So this is a method, a stream of funds to pay for future rail projects.
Yep.
But how do we pay for it now? Like say the Purple Line. I mean, how is that
No,
being financed now?
It's a great question. The purple line is, well, here's the way we pay for major transportation projects in general. As much federal money as we can get, and that varies by project. And then when we need state money, if it's not a toll road, it comes out of the Integrated Transportation Trust Fund. And the money into the trust fund comes from the fees paid by the airlines at the airport, by folks using the port at the port, the gasoline tax that we all pay, the titling taxes and miscellaneous other revenue, but those are most of them. The reason this is kind of important fiscally, if we care about rail projects, is, as we know, the Transportation Trust Fund, which can be used for rail as well as for a bus, as well as for roads, is not in great shape. And it's not in great shape because the economy is changing, because people driving electric vehicles don't pay the gasoline tax. So we're going to have to, during this term, come up with a new approach to transportation funding in general, because using the model of the 20th century is not going to work going forward in the 21st century. And that's an issue that we're talking about in budget and tax. And this would be one piece of the puzzle, is this.
Okay, so thanks. So there's a little imbalance now because we're encouraging more electric vehicles out there.
Even more fuel efficient cars reduces the amount of gasoline tax you collect.
Okay, yeah, thanks.
Yeah.
Appreciate it. Thank you, Madam Chair.
Thank you, Senator. All right, I don't see any additional questions. And I think I heard you say in the response to the Senator Ellis's question that there are 3 or 4 states that have this model. And can you tell me how long they've been in place, or do you have a sense?
I don't know the answer to that.
Okay, we can talk offline. I'm
Yeah,
very
that'd be
curious about what their implementation process might have been and what kind of work was
Absolutely.
done before implementation.
That's why this is before this distinguished committee.
Yes.
I'm
thank
happy
you.
to help.
All right, thank you very much.
Thanks a lot.
Thank you. We have a couple of additional witnesses. Is Samuel Jordan here? He signed up in opposition to the bill. Good afternoon.
Good afternoon. Greetings, and thank you, Madam Chair. And the committee. I'm Samuel Jordan, President of the Baltimore Transit Equity Coalition. Our coalition insists that the committee issue an unfavorable report on Senate Bill 412. We object to the bill's definition that misrepresents 13 years of the successful development history of the Red Line project. The bill's language is subtle but deliberately deceptive. The Red Line Light Rail project was fully approved, fully funded, and awarded a record of decision and a $900 million federal grant in 2013. Its cancellation has created a plateau in the drive to improve transit equity and transit services. An abyss has befallen the Baltimore regional economy. Losses from the multiplier effect alone of the project's planned transit-oriented development of $3 to $6.5 billion have not been recovered. There's been no development project in the Hogan administration bearing such transformative economic power. We also refer to the canceled Red Line as the stolen Red Line. SB 412 creates a novel definition of the Red Line project we call the bogus Red Line. The bill's definition at Title IX, Subtitle 1, Section F attributes the Red Line to the East-West Corridor study of the Central Maryland Regional Transportation Plan process. The stolen Red Line is not addressed in the Central Maryland Regional Transportation Plan, nor in the East-West Corridor study. We propose a definition. Red Line means a rail transit facility using light rail that was approved, funded, and awarded a record of decision by the U.S. DOT in 2013. It is ironic that a Maryland Rail Investment Act encases the Red Line in a definition that ignores investments secured by our Senators Cardin and Van Hollen and sabotages Governor Moore's pledge that he will get the Red Line done. Until the Red Line final environmental impact study is reevaluated, Governor Moore can only be referring to the stolen Red Line. The bogus Red Line has never been federally approved, requiring the project to start from scratch. Chair Griffith and committee, we urge you to issue an unfavorable report for SB 412. Thank you.
Thank you. There are no questions from the committee, so we thank you for your testimony. And we do have one additional witness who's joined us in the Zoom room. Claudia Barber signed up in opposition to the bill. Good afternoon.
Good afternoon. Today, thank you, Madam Chair. Today, our state legislature seeks to revise and replace the definition of the Red Line, and the Transportation Committee of the Caucus of African American Leaders opposes this change on page 11 of Senate Bill 412 that is currently before you. Just as the president of the Baltimore Transit Equity Coalition it reiterated the language we propose in Title IX, Subtitle 1, Definition F is as follows. Red line means a rail transit facility using light rail that was approved, funded, and awarded a record of decision by the USDOT in 2013. So a deviation from this language, if the existing language remains in Title IX, Subtitle 1, we ask the committee to issue an unfavorable report on this legislation. We ask this committee to reconsider the fact that the original Red Line project awarded a record of decision by the U.S. Department of Transportation in 2013. It was fully vetted and should not be disregarded. It is imperative that we use taxpayer funds wisely and not on unvetted projects. We further seek amendments to this act to include a light rail study from BWI Marshall Airport to Annapolis, which would allow thousands of visitors reaching our state by airport to be only a train ride away to the state's capital and state legislature. It would further improve the economy to have such a light rail infrastructure in place when the new Cars Beach is completed and when future Army Navy games are played in Annapolis. Thank you so much for your time, Madam Chair.
Thank you so much for your testimony. Senator Ellis has a question.
Yeah, thank you, Madam Chair. So I'm just curious, I'm just trying to go through the bill really quick and for witnesses, I'm not sure, and maybe I can do this offline, understand why this bill, which is to find a revenue source for these rail projects across the state, is not good for the reinvigorated Red Line, which is committed for by the new governor. Governor Moore talked about that. And I'm not sure, I'm not making the connection, basically. Maybe you can.
I understand.
Offline to really.
I'd like to respond.
You, but yeah.
If I might.
Sure.
The bill itself, in its definition of the red line, is factually incorrect, which should be justification or motivation enough to correct it. But when the governor refers to the red line, he's referring to the red line that was canceled by Governor Hogan. He's not referring to a red line that appears in the Central Maryland Regional Transportation Plan process, because there are no red lines that have been vetted and studied. What we're saying is that, as in any other important study, it isn't valid until it's independently verified. None of the projects in the East-West Corridor study, the North-South study, or in the Central Maryland Regional Transportation Plan study have been independently verified, and only the Red Line Light Rail project has been. And it is also the only project that has been targeted for the receipt of federal funds at this point. So what happens for us is we can't risk a change in definition to divert attention, to divert investment. At this point, all we are saying is something that should be easily understood by any party or any stakeholder, that only when the Red Line Light Rail project itself, that is the one that was stolen from us, the canceled Red Line, when it is reevaluated in collaboration with the U.S. Department of Transportation and modifications are recommended, when those modifications are executed as recommended, then the project itself is eligible for what's called a record of decision. That means it can now then begin receiving and spending the federal funds. So until that reevaluation is undertaken, there has been no independent verification, and only that independent verification should be the basis on which we proceed with the construction of a red line. Also, you see there's a length.
1 second. So I'm just following you with that. So let's talk offline, and I'll work with you and the sponsor to maybe we can alleviate your concerns, because that's a very important issue. We want to make sure we get it right. Okay. Yeah. Thank you, Madam Chair.
Thank you. Thank you very much. I don't see any additional questions. So thank you very much for your testimony. And that will conclude the hearing on Senate Bill 412.
Madam
Colleagues,
Chair, thank you.
thank you. We're going to take a brief break to reset the system. We are scheduled to have a voting session, so please don't go far, members. Thank you.